don't stop. Don't stop.
Asterisk systemic lupus erythematosus, SLE equals lupus is an autoimmune disease characterized by acute and chronic inflammation of various tissues of the body. Autoimmune diseases are illnesses that occur when the body's tissues are attacked by its own immune system. The immune system is a complex system within the body that is designed to fight infectious agents, such as bacteria and other foreign microbes. One of the ways that the immune system fights infections is by producing antibodies that bind to the microbes. People with lupus produce abnormal antibodies in their blood that target tissues within their own body rather than foreign infectious agents. These antibodies are referred to as autoantibodies. Because the antibodies and accompanying cells of inflammation can affect tissues anywhere in the body, lupus has the potential to affect a variety of areas. Sometimes lupus can cause disease of the skin, heart, lungs, kidneys, joints, and or nervous system. Asterisk types of lupus: 1. When only the skin is involved by rash, the condition is called lupus dermatitis or cutaneous lupus erythematosus. 2. A form of cutaneous lupus erythematosus that can be isolated to the skin, without internal disease, is called discoid lupus erythematosus. 3. When internal organs are involved, the condition is referred to as systemic lupus erythematosus, SLE. Both discoid lupus erythematosus and systemic lupus are more common in women than men, about 8 times more common. The disease can affect all ages but most commonly begins from 20 to 45 years of age. Statistics demonstrate that lupus is somewhat more frequent in African Americans and people of Chinese and Japanese descent. Systemic lupus erythematosus, SLE, is the most common type of lupus. SLE is an autoimmune disease in which the immune system attacks its own tissues, causing widespread inflammation and tissue damage in the affected organs. It can affect the joints, skin, brain, lungs, kidneys, blood vessels. There is no cure for lupus, but medical interventions and lifestyle changes can help control it. The seriousness of SLE can range from mild to life-threatening. The disease should be treated by a doctor or a team of doctors who specialize in care of SLE patients. People with lupus that get proper medical care, preventive care, and education can significantly improve function and quality of life. Other types of lupus. 3. Drug-induced lupus is similar to SLE, but occurs as the result of an overreaction to certain medications. Symptoms usually occur 3 to 6 months after starting a medication, and disappear once the medicine is stopped. Dozens of medications have been reported to trigger SLE. However, more than 90% of cases of drug-induced lupus occurs as a side effect of one of the following 6 drugs. 1. Hydralazine, oprazoline, is used for high blood pressure. 2. Quinidine, quinidine gluconate, quinidine sulfate. 3. Procainamide, Pronstill, Procanesar, Procanbid, are used for abnormal heart rhythms. 4. Phenytoin, Dilantin, is used for epilepsy. 5. Isoniazid, Nidrazid, Laniazid, is used for tuberculosis. 6. D-penicillamine, used for rheumatoid arthritis. 5. Neonatal lupus occurs when an infant passively acquires autoantibodies from a mother with SLE. The skin, liver, and blood problems resolve by 6 months, but the most serious problem, congenital heart block, requires a pacemaker and has a mortality rate of about 20%. Risk factors and causes of lupus: is lupus contagious or lupus hereditary? 1. The precise reason for the abnormal autoimmunity that causes lupus is not known. 2. Inherited genes, viruses, ultraviolet light, and certain medications may all play some role. 3. Lupus is not caused by an infectious microorganism and is not contagious from one person to another. 4. Genetic factors increase the tendency of developing autoimmune diseases, and autoimmune diseases such as lupus, rheumatoid arthritis, and autoimmune thyroid disorders are more common among relatives of people with lupus than the general population. Moreover, it is possible to have more than one autoimmune disease in the same individual. Therefore, overlap syndromes of lupus and rheumatoid arthritis, or lupus and scleroderma, etc., can occur. 5. Some scientists believe that the immune system in lupus is more easily stimulated by external factors like viruses or ultraviolet light. 6. Symptoms of lupus can be precipitated or aggravated by only a brief period of sun exposure. 6. It also is known that some women with systemic lupus erythematosus can experience worsening of their symptoms prior to their menstrual periods. 7. This phenomenon, together with the female predominance of systemic lupus erythematosus, suggests that female hormones play an important role in the expression of SLE. 8. This hormonal relationship is an active area of ongoing study by scientists. Research has demonstrated evidence that a key enzyme's failure to dispose of dying cells may contribute the development of systemic lupus erythematosus. The enzyme DNase1 normally eliminates what is called garbage DNA and other cellular debris by chopping them into tiny fragments for easier disposal. Researchers turned off the DNase1 gene in mice. The mice appeared healthy at birth, but after 6 to 8 months, the majority of mice without DNase1 showed signs of systemic lupus erythematosus. 9. Thus, a genetic mutation in a gene that could disrupt the body's cellular waste disposal may be involved in the initiation of systemic lupus erythematosus. Asterisk signs and symptoms of SLE. 1. Common initial and chronic complaints include fever, malaise, joint pains, muscle pains, fatigue. When occurring in conjunction with other signs and symptoms, however, they are considered suggestive. While SLE can occur in both males and females, it is found far more often in women, and the symptoms associated with each sex are different. Females tend to have 1. Greater number of relapses, 2. A low white blood cell count, 3. More arthritis, 4. Raynaud's phenomenon, 5. Psychiatric symptoms. Males tend to have more, 1. Seizures, 2. Kidney disease, 3. Serositis, inflammation of tissues lining the lungs and heart, 4. Skin problems, 5. Peripheral neuropathy. 1. Skin manifestations of SLE. As many as 70% of people with lupus have some skin symptoms. The 3 main categories of lesions are, 1. Chronic cutaneous, discoid, lupus. People with discoid lupus may exhibit thick, red scaly patches on the skin. The skin rash in discoid lupus often is found on the face and scalp. It usually is red and may have raised borders. Discoid lupus rashes are usually painless and do not itch, but scarring can cause permanent hair loss, alopecia. Over time, 5%-10% of those with discoid lupus may develop SLE. 2. Subacute cutaneous lupus, manifests as red, scaly patches of skin but with distinct edges. 3. Acute cutaneous lupus, acute cutaneous lupus manifests as a rash. Some have the classic malar rash, or butterfly rash, associated with the disease. Over half of the people with SLE develop a characteristic red, flat facial rash over the bridge of their nose. Because of its shape, it is frequently referred to as the butterfly rash of SLE. The rash is painless and does not itch. The facial rash, along with inflammation in other organs, can be precipitated or worsened by exposure to sunlight, a condition called photosensitivity. This photosensitivity can be accompanied by worsening of inflammation throughout the body, called a flare of the disease. Typically, with treatment, this rash can heal without permanent scarring. This rash occurs in 30 to 60% of people with SLE. 4. Hair loss, mouth nasal ulcers, and lesions on the skin. 5. Livedo reticularis, a mottled purplish discoloration of the skin. Livedo reticularis can be a normal condition that is simply more obvious when a person is exposed to the cold. It can also be an indicator of impaired circulation. Livedo reticularis has been reported in association with autoimmune diseases, such as systemic lupus erythematosus, abnormal antibodies referred to as phospholipid antibodies, and a syndrome featuring phospholipid antibodies with multiple brain strokes. 2. Muscles and bones manifestations of SLE. The most commonly sought medical attention is for joint pain. More than 90% of those affected will experience joint or muscle pain at some time during the course of their illness. Most SLE patients will develop arthritis during the course of their illness. Arthritis from SLE commonly involves A. Swelling, B. Pain, C. Stiffness, D. Deformity of the small joints of the hands, wrists, and feet. E. Sometimes, the arthritis of SLE can mimic that of rheumatoid arthritis. F. Unlike rheumatoid arthritis, lupus arthritis is less disabling and usually does not cause severe destruction of the joints. Fewer than 10% of people with lupus arthritis will develop deformities of the hands and feet. People with SLE are at particular risk of developing osteoarticular tuberculosis. A possible association between rheumatoid arthritis and SLE has been suggested, and SLE may be associated with an increased risk of bone fractures in relatively young women. Inflammation of muscles, myositis, can cause muscle pain and weakness. This can lead to elevations of muscle enzyme levels in the blood. 3. Blood manifestations of SLE. 1. Anemia is common in children with SLE and develops in about 50% of cases. Low red blood cell counts, hemolytic anemia, can occur. 2. Low platelet count. Low blood clotting factors called platelets, thrombocytopenia, can be caused by lupus, and thrombocytopenia can increase the risk of bleeding. 3. White blood cell count may be due to the disease or a side effect of pharmacological treatment. Referred to as leukopenia or leukopenia. Leukopenia can increase the risk of infection. 4. People with SLE may have an association with antiphospholipid antibody syndrome, a thrombotic disorder, wherein autoantibodies to phospholipids are present in their serum. Abnormalities associated with antiphospholipid antibody syndrome include A. Paradoxical prolonged partial thromboplastin time, which usually occurs in hemorrhagic disorders. B. A positive test for antiphospholipid antibodies. The combination of such findings have earned the term lupus anticoagulant positive. 5. Another autoantibody finding in SLE is the anticardiolipin antibody, which can cause a false positive test for syphilis. 4. Heart manifestations of SLE. 1. SLE may cause pericarditis, inflammation of the outer lining surrounding the heart. 2. Myocarditis, inflammation of the heart muscle. 3. Endocarditis, inflammation of the inner lining of the heart. The endocarditis of SLE is non-infectious, and is also called Liebman-Sachs endocarditis. It involves either the mitral valve or the tricuspid valve. 4. Atherosclerosis also occurs more often and advances more rapidly than in the general population. 5. Lungs manifestations of SLE. 1. SLE can cause pleuritic pain. 2. Inflammation of the pleurae known as pleurisy, which can rarely give rise to shrinking lung syndrome involving a reduced lung volume. 3. Pneumonitis. 4. Chronic diffuse interstitial lung disease. 5. Pulmonary hypertension. 6. Pulmonary emboli. 7. Pulmonary hemorrhage. 8. Inflammation of the lining of the lungs, pleuritis, with pain aggravated by deep breathing, pleurisy, and of the heart, pericarditis, can cause sharp chest pain. The chest pain is aggravated by coughing, deep breathing, certain changes in body position. The heart muscle itself rarely can become inflamed, carditis. It has also been shown that young women with SLE have a significantly increased risk of heart attacks due to coronary artery disease. 6. Kidneys manifestations of SLE. 1. Painless passage of blood or protein in the urine may often be the only presenting sign of kidney involvement. 2. Acute or chronic renal impairment may develop with lupus nephritis, leading to acute or end-stage kidney failure. 3. Because of early recognition and management of SLE, end-stage renal failure occurs in less than 5% of cases, except in the Black population, where the risk is many times higher. 4. The histological hallmark of SLE is membranous glomerulonephritis with wire loop abnormalities. This finding is due to immune complex deposition along the glomerular basement membrane, leading to a typical granular appearance in immunofluorescence testing. 5. Kidney inflammation in SLE, lupus nephritis, can cause a leakage of protein into the urine. B. Fluid retention. C. High blood pressure. D. Kidney failure. This can lead to further fatigue and swelling, edema, of the legs and feet. With kidney failure, machines are needed to cleanse the blood of accumulated waste products in a process called dialysis. 7 Neuropsychiatric manifestations of SLE. 1 Neuropsychiatric syndromes can result when SLE affects the central or peripheral nervous system. 2 The American College of Rheumatology defines 19 neuropsychiatric syndromes in systemic lupus erythematosus. 3 The diagnosis of neuropsychiatric syndromes concurrent with SLE, now termed as NPSL, is one of the most difficult challenges in medicine, because it can involve so many different patterns of symptoms, some of which may be mistaken for signs of infectious disease or stroke. For a common neurological disorder people with SLE have is headache, although the existence of a specific lupus headache and the optimal approach to headache in SLE cases remains controversial. 5 Cognitive dysfunction. 6 Mood disorder. 7 Cerebrovascular disease, 9 Seizures. 10 Polyneuropathy. 11 Anxiety disorder. 12 Psychosis. 13 Depression. 14 In some extreme cases, personality disorders. 15 Steroid psychosis can also occur as a result of treating the disease. 16 Intracranial hypertension syndrome, characterized by A. An elevated intracranial pressure. B. Papilledema, C. Headache with occasional abducens nerve paresis. D. Absence of a space-occupying lesion. E. Ventricular enlargement. F. N. Normal cerebrospinal fluid chemical. G. Hematological constituents. 16 R. Acute confusional state. 17 Guillain-Barré syndrome. 18 Aseptic meningitis. 19 Autonomic disorder. 20 Demyelinating syndrome. 21 Mononeuropathy, which might manifest as mononeuritis multiplex. 22 Movement disorder, more specifically, chorea. 23 Myasthenia gravis. 24 Myelopathy. 25 Cranial neuropathy. 26 Plexopathy. Neurological disorders contribute to a significant percentage of morbidity and mortality in people with lupus. As a result, the neural side of lupus is being studied in hopes of reducing morbidity and mortality rates. One aspect of this disease is severe damage to the epithelial cells of the blood-brain barrier. In certain regions, depression affects up to 60% of women with SLE. Involvement of the brain can cause personality changes, thought disorders, psychosis, seizures, coma. Lupus of the nervous system, neurologic lupus, can lead to damage to nerves, cause numbness, tingling, weakness of the involved body parts or extremities. Brain involvement is referred to as lupus cerebritis. 8 Hair loss manifestations of SLE. Many people with SLE experience hair loss, alopecia. Often, this occurs simultaneously with an increase in the activity of their disease. The hair loss can be patchy or diffuse and appear to be more like hair thinning. 9 Blood vessels manifestations of SLE. 1 Inflammation of blood vessels, vasculitis, that supply oxygen to tissues can cause isolated injury to a nerve, the skin, or an internal organ. The blood vessels are composed of arteries that pass oxygen-rich blood to the tissues of the body and veins that return oxygen-depleted blood from the tissues to the lungs. 2 Vasculitis is characterized by inflammation with damage to the walls of various blood vessels. The damage blocks the circulation of blood through the vessels and can cause injury to the tissues that are supplied with oxygen by these vessels. 3 Some people with SLE have Raynaud's phenomenon. Raynaud's phenomenon causes the blood vessels of the hands and feet to spasm, especially upon exposure to cold. The blood supply to the fingers and/or toes then becomes compromised, causing 1 Blanching, 2 Whitish, 3 Bluish discoloration, 4 Pain and numbness in the exposed fingers and toes. 10 Eyes manifestations of SLE. Eye involvement is seen in up to 1/3 of people. The most common diseases are 1 Dry eye syndrome, 2 Secondary Sjogren's syndrome, 3 Episcleritis, 4 Scleritis, 5 Retinopathy, more often affecting both eyes than one. 6 Ischemic optic neuropathy, 7. Retinal detachment. 8. Secondary angle closure glaucoma may occur. 9. In addition, the medications used to treat SLE can cause eye disease. A. Long-term glucocorticoid use can cause A. Cataracts. B. Secondary open-angle glaucoma. C. Long-term hydroxychloroquine treatment can cause vortex keratopathy and maculopathy. 11. Reproductive manifestations of SLE. While most pregnancies have positive outcomes, there is a greater risk of adverse events occurring during pregnancy. 1. SLE causes an increased rate of fetal death in utero and spontaneous abortion, miscarriage. The overall live birth rate in people with SLE has been estimated to be 72%. Pregnancy outcome appears to be worse in people with SLE whose disease flares up during pregnancy. 2. Neonatal lupus is the occurrence of SLE symptoms in an infant born from a mother with SLE, A. Most commonly presenting with a rash resembling discoid lupus erythematosus. B. Heart block or enlargement of the liver and spleen. C. Neonatal lupus is usually benign and self-limited. 12. Systemic manifestations of SLE. 1. Fatigue in SLE is probably multifactorial and has been related to not only disease activity or complications such as anemia or hypothyroidism. 2. Pain. 3. Depression. 4. Poor sleep quality. 5. Poor physical fitness. 6. Lack of social support. 7. Other diseases and conditions that can accompany lupus include A. Fibromyalgia. B. Coronary heart disease. C. Non-bacterial valvular heart disease. D. Pancreatitis. E. Esophagus disease with difficulty swallowing, dysphagia. F. Swollen lymph nodes, lymphadenopathy. G. Liver disease, leukemia hepatitis. H. Infections. I. Tendency to spontaneous blood clotting and thrombosis. Asterisk causes of SLE. 1. SLE is presumably caused by a genetic susceptibility coupled with an environmental trigger which results in defects in the immune system. One of the factors associated with SLE is vitamin D deficiency. 1. Genetics. SLE does run in families, but no single causal gene has been identified. Instead, multiple genes appear to influence a person's chance of developing lupus when triggered by environmental factors. 1. HLA class I, class II, and class III genes are associated with SLE, but only classes I and II contribute independently to increased risk of SLE. 2 other genes which contain risk variants for SLE are 2IRF5, 3 PTPN22, 4 STAT4, 5 CDKN1A, 6 ITGAM, 7 BLK, 8 TNFSF4, 9 BANK1. Some of the susceptibility genes may be population-specific. 10 Genetic studies of the rates of disease in families supports the genetic basis of this disease with a heritability of 66%. 11 Identical, monozygotic, twins were found to share susceptibility to the disease at 35% rate compared to fraternal, dizygotic, twins and other full siblings who only showed a 2 to 5% concordance in shared inheritance. 12 Since SLE is associated with many genetic regions, it is likely an oligogenic trait, meaning that there are several genes that control susceptibility to the disease. SLE is regarded as a prototype disease due to the significant overlap in its symptoms with other autoimmune diseases. 2 Drug reactions. Drug-induced lupus erythematosus is a, generally, reversible condition that usually occurs in people being treated for a long-term illness. Drug-induced lupus mimics SLE. However, symptoms of drug-induced lupus generally disappear once the medication that triggered the episode is stopped. More than 38 medications can cause this condition, the most common of which are procainamide, isoniazid, hydralazine, quinidine, phenytoin. 3 Non-systemic forms of lupus. Discoid, cutaneous. Lupus is limited to skin symptoms and is diagnosed by biopsy of rash on the face, neck, scalp, arms. Approximately 5% of people with DLE progress to SLE. Pathophysiology of lupus. SLE is triggered by environmental factors that are unknown. 1 In SLE, the body's immune system produces antibodies against itself, particularly against proteins in the cell nucleus. These antibody attacks are the immediate cause of SLE. 2. SLE is a chronic inflammatory disease believed to be a type 3 hypersensitivity response with potential type 2 involvement. Reticulate and stellate acral pigmentation should be considered a possible manifestation of SLE, and high titers of anticardiolipin antibodies, or a consequence of therapy. 3. People with SLE have intense polyclonal B cell activation, with a population shift towards immature B cells. Memory B cells with increased CD27+/IgD are less susceptible to immunosuppression. CD27-IgD memory B cells are associated with increased disease activity and renal lupus. 4. T cells, which regulate B cell responses and infiltrate target tissues, have defects in 1. Signaling, 2. Adhesion, 3. co-stimulation, 4. gene transcription, 5. alternative splicing. The following involved in the inflammatory process and are potential therapeutic targets: A. The cytokines B lymphocyte stimulator, BLyS. B. Interleukin 6. C. Interleukin 17. D. Interleukin 18. E-type I interferons. F. Tumor necrosis factor alpha, TNF-alpha. In the complement system, low C3 levels are associated with systemic lupus erythematosus. 2. Cell death signaling. A. Apoptosis is increased in monocytes and keratinocytes. Expression of FOS by B cells and T cells is increased. B. There are correlations between the apoptotic rates of lymphocytes and disease activity. C. Necrosis is increased in T lymphocytes. D. Tingible body macrophages, TBMs, large phagocytic cells in the germinal centers of secondary lymph nodes, express CD68 protein. These cells normally engulf B cells that have undergone apoptosis after somatic hypermutation. In some people with SLE, significantly fewer TBMs can be found, and these cells rarely contain material from apoptotic B cells. Also, unengaged apoptotic nuclei can be found outside of TBMs. This material may present a threat to the tolerization of B cells and T cells. Dendritic cells in the germinal center may endocytose such antigenic material and present it to T cells, activating them. Also, apoptotic chromatin and nuclei may attach to the surfaces of H follicular dendritic cells and make this material available for activating other B cells that may have randomly acquired self-specificity through somatic hypermutation. Necrosis, a pro-inflammatory form of cell death, is increased in T lymphocytes, due to mitochondrial dysfunction, oxidative stress, depletion of ATP. 3. Clearance deficiency. Impaired clearance of dying cells is a potential pathway for the development of this systemic autoimmune disease. This includes deficient phagocytic activity and scant serum components in addition to increased apoptosis. SLE is associated with defects in apoptotic clearance, and the damaging effects caused by apoptotic debris. Early apoptotic cells express eat-me signals, of cell surface proteins such as phosphatidylserine, that prompt immune cells to engulf them. Apoptotic cells also express find-me signals, to attract macrophages and dendritic cells. When apoptotic material is not removed correctly by phagocytes, they are captured instead by antigen-presenting cells, which leads to development of anti-nuclear antibodies. Monocytes isolated from whole blood of people with SLE show reduced expression of CD44 surface molecules involved in the uptake of apoptotic cells. Most of the monocytes and tingible body macrophages, TBMs, which are found in the germinal centers of lymph nodes, even show a definitely different morphology. They are smaller or scarce and die earlier. Serum components like complement factors, CRP, and some glycoproteins are, furthermore, decisively important for an efficiently operating phagocytosis. With SLE, these components are often missing, diminished, or inefficient. Recent research has found an association between certain people with lupus, especially those with lupus nephritis, and an impairment in degrading neutrophil extracellular traps, NETs. These were due to DNA SE1 inhibiting factors, or net protecting factors in people's serum, rather than abnormalities in the DNA SE1 itself. DNA SE1 mutations in lupus have so far only been found in some Japanese cohorts. The clearance of early apoptotic cells is an important function in multicellular organisms. It leads to a progression of the apoptosis process and finally to secondary necrosis of the cells if this ability is disturbed. Necrotic cells release nuclear fragments as 1. Potential autoantigens. 2. As well as internal danger signals. 3. Inducing maturation of dendritic cells, DCS. 4. Since they have lost their membrane's integrity. Increased appearance of apoptotic cells also stimulates inefficient clearance. That leads to maturation of DCS and also to the presentation of intracellular antigens of late apoptotic or secondary necrotic cells, via MHC molecules. Autoimmunity possibly results by the extended exposure to nuclear and intracellular autoantigens derived from late apoptotic and secondary necrotic cells. B and T cell tolerance for apoptotic cells is abrogated, and the lymphocytes get activated by these autoantigens. Inflammation and the production of autoantibodies by plasma cells is initiated. A clearance deficiency in the skin for apoptotic cells has also been observed in people with cutaneous lupus erythematosus, CLE. 4. Germinal centers. 1. In healthy conditions, apoptotic lymphocytes are removed in germinal centers, GC, by specialized phagocytes, the tingible body macrophages, TBM, which is why no free apoptotic and potential autoantigenic material can be seen. 2. In some people with SLE, buildup of apoptotic debris can be observed in GC because of an ineffective clearance of apoptotic cells. 4. In close proximity to TBM, follicular dendritic cells, FDC, are localized in GC, which attach antigen material to their surface and, in contrast to bone marrow-derived DC, neither take it up nor present it via MHC molecules. 5. Autoreactive B cells can accidentally emerge during somatic hypermutation and migrate into the germinal center light zone. 6. Autoreactive B cells, maturated coincidentally, normally do not receive survival signals by antigen planted on follicular dendritic cells and perish by apoptosis. 7. In the case of clearance deficiency, apoptotic nuclear debris accumulates in the light zone of GC and gets attached to FDC. 8. This serves as a germinal center survival signal for autoreactive B cells. 9. After migration into the mantle zone, autoreactive B cells require further survival signals from autoreactive helper T cells, which promote the maturation of autoantibody producing plasma cells and B memory cells. 10. In the presence of autoreactive T cells, a chronic autoimmune disease may be the consequence. 6. Anti-NRNP autoimmunity. 1. Anti-NRNP autoantibodies to NRNPA and NRNPC initially targeted restricted, proline-rich motifs. 2. Antibody binding subsequently spread to other epitopes. 3. The similarity and cross-reactivity between the initial targets of NRNP and SM autoantibodies identifies a likely commonality in cause and a focal point for intermolecular epitope spreading. 7. Others. 1. Elevated expression of HMGB1 was found in the sera of people and mice with systemic lupus erythematosus, high mobility group box 1. HMGB1 is a nuclear protein participating in chromatin architecture and transcriptional regulation. Recently, there is increasing evidence HMGB1 contributes to the pathogenesis of chronic inflammatory and autoimmune diseases due to its inflammatory and immune-stimulating properties. Diagnosis. Micrograph of a section of human skin prepared for direct immunofluorescence using an anti-IgG antibody. The skin is from a person with systemic lupus erythematosus and shows IgG deposits at two different places. The first is a band-like deposit along the epidermal basement membrane. Lupus band test is positive. B. The second is within the nuclei of the epidermal cells. Anti-nuclear antibodies are present. 1. Laboratory tests. 1. Anti-nuclear antibody, ANA, testing an anti-extractable nuclear antigen, anti-ENA, form the mainstay of serologic testing for SLE. If ANA is negative, the disease can be ruled out. Several techniques are used to detect ANAs. One the most widely used is indirect immunofluorescence, IF. The pattern of fluorescence suggests the type of antibody present in the people's serum. 2. Direct immunofluorescence can detect deposits of immunoglobulins and complement proteins in the people's skin. When skin not exposed to the sun is tested, a positive directive, the so-called lupus band test, is an evidence of systemic lupus erythematosus. ANA screening yields positive results in many connective tissue disorders and other autoimmune diseases, and may occur in normal individuals. Subtypes of antinuclear antibodies, 1 include anti-Smith 2 anti-double-stranded DNA, dsDNA, antibodies, which are linked to SLE. 3 antihistone antibodies, which are linked to drug-induced lupus. Anti-DNA antibodies are highly specific for SLE, they are present in 70% of cases, whereas they appear in only 0.5% of people without SLE. The anti-DNA antibody titers also tend to reflect disease activity, although not in all cases. 2 anti-U1RNP, which also appears in systemic sclerosis and mixed connective tissue disease. 3 SSA, or anti-RO, 4 SSB, or anti-LA, both of which are more common in Sjogren's syndrome. SSA and SSB confer a specific risk for heart conduction block in neonatal lupus. 5 complement system levels, low levels suggest consumption by the immune system. 6 electrolytes and kidney function, disturbed if the kidney is involved. 7 liver enzymes. 8 complete blood count. 9 The lupus erythematosus, LE, cell test was commonly used for diagnosis, but it is no longer used because, A. The LE cells are only found in 50 to 75% of SLE cases. B. And they are also found in some people with rheumatoid arthritis. C. Scleroderma. D. Drug sensitivities. Because of this, the LE cell test is now performed only rarely and is mostly of historical significance. Diagnostic criteria. Some physicians make a diagnosis on the basis of the American College of Rheumatology, ACR, classification criteria. The criteria, however, were established mainly for use in scientific research, including use in randomized controlled trials which require higher confidence levels, so many people with SLE may not pass the full criteria. Criteria, for the purpose of identifying people for clinical studies, a person has SLE if any 4 out of 11 symptoms are present simultaneously or serially on 2 separate occasions. 1 malar rash, rash on cheeks, sensitivity equals 57%, specificity equals 96%. 2 discoid rash, red, scaly patches on skin that cause scarring, sensitivity equals 18%, specificity equals 99%. 3 serositis, pleurisy, inflammation of the membrane around the lungs, or pericarditis, inflammation of the membrane around the heart, sensitivity equals 56%, specificity equals 86%, pleural is more sensitive, cardiac is more specific. 4 oral ulcers, includes oral or nasopharyngeal ulcers, sensitivity equals 27%, specificity equals 96%. 5 arthritis, non-erosive arthritis of 2 or more peripheral joints, with tenderness, swelling, or effusion, sensitivity equals 86%, specificity equals 37%. 6 photosensitivity, exposure to ultraviolet light causes rash, or other symptoms of SLE flare-ups, sensitivity equals 43%, specificity equals 96%. 7 blood hematologic disorder, hemolytic anemia, low red blood cell count, leukopenia, white blood cell count 4000/L, lymphopenia, 1500/L, or low platelet count, 100,000/L, in the absence of offending drug, sensitivity equals 59%, specificity equals 89%. Hypocomplementemia is also seen, due to either consumption of C3 and C4 by immune complex-induced inflammation or to congenitally complement deficiency, which may predispose to SLE. 8. Renal disorder, more than 0.5 g per day protein in urine or cellular casts seen in urine under a microscope, sensitivity equals 51%, specificity equals 94%. 9. Anti-nuclear antibody test positive, sensitivity equals 99%, specificity equals 49%. 10. Immunologic disorder, A positive anti-Smith, B anti-dsDNA, C antiphospholipid antibody, or false positive serological test for syphilis, sensitivity equals 85%, specificity equals 93%. Presence of anti-ssDNA in 70% of cases, though also positive with rheumatic disease and healthy persons. 11. Neurologic disorder, seizures or psychosis, sensitivity equals 20%, specificity equals 98%. Other than the ACR criteria, people with lupus may also have fever, over 100 degree F/37.7 degrees Celsius, extreme fatigue, hair loss, fingers turning white or blue when cold, Raynaud's phenomenon. Criteria for individual diagnosis: 1. Some people, especially those with antiphospholipid syndrome, may have SLE without 4 of the above criteria, and also SLE may present with features other than those listed in the criteria. 2. Recursive partitioning has been used to identify more parsimonious criteria. This analysis presented 2 diagnostic classification trees. 1. Simplest classification tree, SLE is diagnosed if a person has an immunologic disorder, anti-DNA antibody, anti-Smith antibody, false positive syphilis test, or LE cells, or malar rash. It has sensitivity equals 92% and specificity equals 92%. 2. Full classification tree, uses 6 criteria. It has sensitivity equals 97% and specificity equals 95%. Asterisk treatment, the treatment of SLE involves preventing flares and reducing their severity and duration when they occur. 1. Treatment can include corticosteroids and antimalarial drugs. 2. Certain types of lupus nephritis such as diffuse proliferative glomerulonephritis require intermittent cytotoxic drugs. These drugs include cyclophosphamide and mycophenolate. Cyclophosphamide increases the risk of A. Developing infections. B. Pancreas problems. C. High blood sugar. D. And high blood pressure. 3. Hydroxychloroquine was approved by the FDA for lupus in 1955. 4. Belimumab, Benlysta, are used for SLE off-label. 3. Medications. Due to the variety of symptoms and organ system involvement with SLE, its severity in an individual must be assessed in order to successfully treat SLE. Mild or remittent disease may, sometimes, be safely left untreated. Asterisk if required, nonsteroidal anti-inflammatory drugs and antimalarials may be used. Asterisk medications such as prednisone, mycophenolic acid, and tacrolimus have been used in the past. Disease-modifying antirheumatic drugs, disease-modifying antirheumatic drugs, DMARDs, are used preventively to 1. Reduce the incidence of flares. 2. Reduce the progress of the disease. 3. Reduce need for steroid use. When flares occur, they are treated with corticosteroids. DMARDs commonly in use are antimalarials such as A-hydroxychloroquine. B. Immunosuppressants, e.g. methotrexate and azathioprine. Hydroxychloroquine is an FDA-approved antimalarial used for constitutional, cutaneous, and articular manifestations. Hydroxychloroquine has relatively few side effects, and there is evidence that it improves survival among people who have SLE. C. Cyclophosphamide is used for severe glomerulonephritis or other organ-damaging complications. D. Mycophenolic acid is also used for treatment of lupus nephritis, but it is not FDA approved for this indication, and FDA is investigating reports that it may be associated with birth defects when used by pregnant women. Immunosuppressive drugs. In more severe cases, medications that modulate the immune system, primarily corticosteroids and immunosuppressants, are used to control the disease and prevent recurrence of symptoms, known as flares. Depending on the dosage, People who require steroids may develop 1. Cushing's syndrome, 2. Obesity, 3. Puffy round face, 4. Diabetes mellitus, 5. Increased appetite, 7. Difficulty sleeping, 8. Osteoporosis, 9. These may subside if and when the large initial dosage is reduced, but long-term use of even low doses can cause elevated blood pressure and cataracts. Analgesia. Since a large percentage of people with SLE have varying amounts of chronic pain, stronger prescription analgesics, painkillers, may be used if over-the-counter drugs, mainly nonsteroidal anti-inflammatory drugs, do not provide effective relief. Potent NSAIDs such as indomethacin and diclofenac are relatively contraindicated for people with SLE because they increase the risk of kidney failure and heart failure. Pain is typically treated with opioids, varying in potency based on the severity of symptoms. When opioids are used for prolonged period, A. Drug tolerance. B. Chemical dependency. C. Addiction may occur. Opiate addiction is not typically a concern since the condition is not likely to ever completely disappear. Thus, lifelong treatment with opioids is fairly common for chronic pain symptoms, accompanied by periodic titration that is typical of any long-term opioid regimen. Intravenous immunoglobulins, IVIGs. 1. Intravenous immunoglobulins may be used to control SLE with organ involvement, or vasculitis. It is believed that they reduce antibody production or promote the clearance of immune complexes from the body, even though their mechanism of action is not well understood. Unlike immunosuppressives and corticosteroids, IVIGs do not suppress the immune system, so there is less risk of serious infections with these drugs. Lifestyle changes. 1. Avoiding sunlight in SLE is critical, since sunlight is known to exacerbate skin manifestations of the disease. 2. Avoiding activities which induce fatigue is also important, since those with SLE fatigue easily and it can be debilitating. These two problems can lead to people becoming housebound for long periods of time. 3. Drugs unrelated to SLE should be prescribed only when known not to exacerbate the disease. 4. Occupational exposure to silica, pesticides, and mercury can also worsen the disease. Kidney transplantation. Kidney transplants are the treatment of choice for end-stage kidney disease, which is one of the complications of lupus nephritis, but the recurrence of the full disease is common in up to 30% of people. Antiphospholipid syndrome. Approximately 20% of people with SLE have clinically significant levels of antiphospholipid antibodies, which are associated with antiphospholipid syndrome. Antiphospholipid syndrome is also related to the onset of neural lupus symptoms in the brain. In this form of the disease, the cause is very different from lupus. Thromboses, blood clots or sticky blood, form in blood vessels, which prove to be fatal if they move within the bloodstream. If the thromboses migrate to the brain, they can potentially cause a stroke by blocking the blood supply to the brain. If this disorder is suspected in people, brain scans are usually required for early detection. These scans can show localized areas of the brain where blood supply has not been adequate. The treatment plan for these people requires anticoagulation. Often, low-dose aspirin is prescribed for this purpose, although for cases involving thrombosis anticoagulants such as warfarin are used. Management of pregnancy. 1. While most infants born to mothers who have SLE are healthy, pregnant mothers with SLE should remain under medical care until delivery. 2. Neonatal lupus is rare, but identification of mothers at highest risk for complications allows for prompt treatment before or after birth. 3. In addition, SLE can flare up during pregnancy, and proper treatment can maintain the health of the mother longer. 4. Women pregnant and known to have anti-RO, SSA, or anti-LA antibodies, SSB, often have echocardiograms during the 16th and 30th weeks of pregnancy to monitor the health of the heart and surrounding vasculature. 5. Contraception and other reliable forms of pregnancy prevention is routinely advised for women with SLE, since getting pregnant during active disease was found to be harmful. 6. Lupus nephritis was the most common manifestation. Prognosis 1. No cure is available for SLE, but there are many treatments for the disease. 2. In the 1950s, most people diagnosed with SLE lived fewer than 5 years. Today, over 90% now survive for more than 10 years, and many live relatively symptom-free. 80 to 90% can expect to live a normal lifespan. 3. Mortality rates are however elevated compared to people without SLE. 4. Prognosis is typically worse for men and children than for women. However, if symptoms are present after age 60, the disease tends to run a more benign course. 5. Early mortality, within 5 years, is due to organ failure or overwhelming infections, both of which can be altered by early diagnosis and treatment. 6. The mortality risk is fivefold when compared to the normal population in the late stages, which can be attributed to cardiovascular disease from accelerated atherosclerosis, the leading cause of death for people with SLE. 7. To reduce the potential for cardiovascular issues, high blood pressure and high cholesterol should be prevented or treated aggressively. 8. Steroids should be used at the lowest dose for the shortest possible period, and other drugs that can reduce symptoms should be used whenever possible.